So thanks for having me today to speak. Sorry I couldn't be there in person. So I'm just going to give you an overview of the MSM programme in Scotland and some work that we have been involved in assessing the impact quite early on in the programme. So I just say next slide. Thank you. So in November 2015, the GCVI, which is the NITAG for the UK, recommended vaccination of MSM. This is because they realised that MSM are at high risk of HPV infection and associated disease, and they received little to no benefit from the girls-only programme at the time. And this was following revised modelling work undertaken by Public Health England, and they recommended that it would be rolled out in sexual health clinics. Next slide, please. So they said, so it was implemented in the 1st of July 2017, and it was to be implemented in sexual health clinics and HIV clinics. The main targeted group would be the MSM under age 45 and under, but this also included prisoners and transgender women. There's also a clinical discretion group. They're not part of the main programme, but can be vaccinated if their clinician thinks it would be useful. And this includes HIV positive individuals, sex workers, and MSM over the age of 45. Gardasil is the current vaccine of choice in the programme, and it's a 3-dose schedule for those aged 15 to 45, given at the first month, and then you have to have 3 within 3 or 12 months. And those aged under 15 would only require 2 doses, but that it's quite rare for them to attend sexual health clinic. Next slide, please. So this is a graph of the vaccine uptake using prescription data. So this is taken from the National Sexual Health System in Scotland, and this is presenting the first 2 years of uptake. So it's been fairly high across Scotland, 65% overall. This is the eligible, and this is the denominator is the MSM attending for sexual health, and it's fairly high across all the different health boards of Scotland. The main 2 ones to focus on would be Greater Glasgow and Clyde and Lothian, and that's where majority of MSM population would attend sexual health. Next slide, please. Sorry, I forgot to say that was first dose uptake. So this graph is showing completed uptake. So completion rates are not great. However, we think this might be underestimated due to the fact that we rely on prescription data. So we know that some sexual health clinics will prescribe the 3 doses at the first appointment, and so then we do not capture the subsequent doses. However, there's also the issue of men who have sex with men not attending maybe their second or their third appointment, and also because a lot of it's opportunistic as well. If they attend for one appointment, you may never see them again. So next slide, please. And this is just vaccine uptake by age group, and it shows that over half of the vaccines have been given to those in the age group 20 to 29, but we also do have quite a significant amount of vaccines going into older men. Next slide, please. So going on to vaccine impact, there's 2 main routes that we intend to go down. One is HPV-related disease, and this will be through looking at diagnoses of genital warts via prescription data. And the other is HPV prevalence, and this is measuring the prevalence of HPV in rectal swabs and MSM who attend for sexual health. Next slide, please. So looking at genital wart treatment prescriptions. So the data again are extracted from the National Sexual Health Database, which covers the whole of Scotland. It includes prescriptions for pidoflatoxin, imiquimod, and also cryotherapy. And the data, this is actually a mistake, sorry, the data are actually for individuals, not prescriptions, so there should be less duplication, but there still will be duplication for for reoccurrence. And we don't know where the site of the genital warts was diagnosed. Next slide, please. So this graph shows the number of genital wart prescriptions in Scotland from 2010 to 2018, split by sex and MSM. So you can see that we have seen a decrease in prescriptions since 2012, which is surprisingly early because that's when we introduced Gardasil in the national programme, and that's increased in males and females quite consistently each year. MSM, on the other hand, it's maintained to be stable. However, it's important to note in 2017 we introduced HIV PrEP, which meant we have a lot more attendances in 2017 and 18 of MSM at sexual health clinics, and this may inflate the denominator and increase the opportunity to diagnose genital warts. So it also could be quite early on in the programme, so it's just something that we're going to keep an eye on. Just next slide, please. So this is the study that we published last year, looking at prevalence in rectal swabs. So these were taken between October 2006 and February 2017, originally for gonorrhea and chlamydia testing. It's important to note that we do not know the sexual orientation, but because it's a rectal swab, we take that as a proxy for MSM status. The sexual health clinic, there was only one sexual health clinic that was involved in the study, but that covers the city of Edinburgh and the outlying counties, which cover 16% of the population of Scotland. And the residual samples were tested in types for 24 high-risk and low-risk types. Overall, 1,210 samples were sufficient for testing and were included in the analysis, and the prevalence of any HPV, high-risk HPV and vaccine-type HPV was assessed. Next slide, please. So this graph is showing the prevalence of different HPV type combinations by age group. So overall, HPV prevalence was really high in MSM across all the different groups and also at different age groups. So generally there was an increase by age, but once you got to the older age groups, there was no significant difference. The only difference is HPV 6 and 11, where the increase was mainly seen in the 21 and 25-year-olds, but that was consistent with genital wart diagnoses. And if you look at the quadrivalent vaccine, around 50% of our sample were infected with a quadrivalent vaccine type, but that also meant that 50% of the sample were not infected, so therefore the vaccine should have some measurable effect. Next slide, please. So this is something that we've just done recently. So there was another sample taken on post introduction of the HPV vaccine, and this was again rectal swabs, and this was a year after the programme was initiated, and it was 1,235 samples and were included at this point. They were taken in the same setting and the same median age. It was the same median age of men in the baseline and the second sample, which was 33 years. However, overall HPV prevalence was actually higher in the post-vaccine sample. However, next slide, please. When we looked at HPV 16-18, we seen just a significant decrease in the post-vaccine sample compared to the pre-vaccine sample. However,
Ross, can you repeat? Are you there? Yeah, it's froze. Wait a minute, Ross. We can't. Sorry, Ross. Can you go back to the slide? Yeah. Can you start again with the HPV prevalence and type and rectal swab slide?
Yes.
Yeah. The vaccine.
So you can see 16-18, we've seen a decrease in the post-vaccine sample compared to the pre-vaccine sample. It's just a significant decrease. And in HPV 6 and 11, we've seen an increase, but we're seeing that it's an early in the programme, and we do not know the vaccination status of the men in which the samples were taken, so we may have not captured. So next slide, please. Thank you. So in conclusion, HPV uptake in MSM has been relatively high in those attending sexual health clinics. There was MSM that were vaccinated that actually had no prior attendance at sexual health at all. So that was 38% of those vaccinated were actually now attending sexual health, which is good. Completion rates are likely to be underestimated due to the data issues that I had described. And treatment for genital warts remains stable in MSM, but again, it's still early days. Prevalence of HPV is high in MSM and generally increased with age, but similar in older age groups. 50% of samples were negative for a quadrivalent vaccine type, and indications of vaccine effect on HPV prevalence, but there is further sampling needed. And some future work in which we're going to undertake is to link vaccine status to genital wart treatment, because it's a new methodology that we now do using the National Sexual Health System. We can also now we could potentially link vaccine status to prevalence data, and in the long term, we'll also be looking at HPV-driven cancers in men. Okay, next slide, please. I just want acknowledgements to thank the sexual health clinic staff and the lab staff throughout Scotland and colleagues within HBS and IST. Thanks very much.